Hi, and welcome back to Student Nurses Success. We're going to talk about congenital heart defects. Now, congenital heart defects can be a little complicated, but I think I've broken this down to a few simple concepts to help you out. I'd like to first begin by just talking about fetal development. A congenital heart defect means that there is a defect in the development of the heart while the baby was in utero. So the baby was actually born with this defect. Now, the heart develops very early in pregnancy. You can hear a heartbeat somewhere about 5 to 6 weeks, and the valves in the chambers are formed by about 12 weeks. So, this heart develops very, very early in the pregnancy. Now, there's two things we should talk about with regard to fetal development of the heart. One is the foramen ovale, and the second one is the ductus arteriosus. Both of these are in place in order to help make the fetal heart more efficient. With a fetal heart, there is no need to send blood to the lungs. The baby's not breathing, the baby's blood is being oxygenated by the mother. So, to improve the efficiency, there is something called the foramen ovale and the ductus arteriosus. The foramen ovale is actually an opening between the two atrias. So between the right atrium and the left atrium, there's a tiny opening. And that opening allows blood to move from the right atrium to the left atrium and actually skip the whole process of sending that blood to the baby's lungs because it's just not necessary. Now, the foramen ovale should close soon after birth, and that closes due to pressure changes in the left side of the heart. When the baby breathes, expands those lungs once he or she is born, what happens is that pressure actually closes that little flap called the foramen ovale. Now, the ductus arteriosus is a vessel that connects the pulmonary artery with the aorta. And again, this improves efficiency. It allows blood to go and skip from the pulmonary artery, all the way out to the aorta. So it doesn't have to go to the lungs because there's no need. Now, the ductus will actually start to close down after birth, and it closes down due to changes in oxygen saturation and from withdrawal of prostaglandin E2 from the placenta. So both of these things will actually help close the duct. Now, what are the causes of congenital heart defects? One can be genetics, and the second is environmental. We know that prenatal infections, maybe radiation exposure, alcohol exposure, or some type of event that occurs early in the pregnancy can alter the development. And let's talk about the pathophysiology. We've broken this down into two simple concepts. There's either shunts or obstructions. Now, shunts has to do with blood movement. And a shunt means that there's abnormal movement of blood or flow through the heart. So basically, a shunt means that blood is going the wrong way in the heart. Now, shunts can be either acyanotic or cyanotic. Acyanotic means that the baby is actually the oxygen content of the blood is sufficient. Now, I'm not saying that the amount of blood is sufficient because sometimes that may not be the case, but the amount of oxygen in the blood in an acyanotic defect is sufficient. So that's a good oxygen saturation. With an acyanotic shunt, we know that there's movement from the left side of the heart to the right side of the heart. So what happens is that's moving the wrong way. But the left side is oxygenated. And so this oxygenated blood is moving from the left side to the right side and getting oxygenated again. So it's not efficient and it's not what we want, but the oxygen content is sufficient. Now, a cyanotic shunt means that the movement of blood is from the right side of the heart to the left side and has skipped oxygenation into the lungs. In these particular cases, the problem is that since the blood is not going to the lungs, it's not picking up oxygen. So the oxygen content of the blood is not enough. And so in these particular cases, the baby may appear blue or cyanotic. Now we also have obstructions. Obstructions means that there is slow flow through narrowed areas of the heart, or perhaps there's not even flow through an area of a heart. It's completely obstructed. So although it's going the correct way, it starts to get backed up or slow. So it's narrowed, and so the blood will actually start to back up with obstructions. With obstructions, the amount of flow going through is decreased and not sufficient. However, obstructions are acyanotic. The oxygen content is there. It's just the amount of flow is not. And so we see decreased cardiac output. So with shunts, we can actually see either a decrease in O2 sats or normal O2 sats. It just depends if it's acyanotic or cyanotic. With obstructions, we start to see a decrease in cardiac output and actually a backup. So now let's move in and talk about our acyanotic heart defects. Acyanotic heart defects means that we have enough oxygen saturation of the blood. So O2 sats are good. However, in an acyanotic heart defect, it is likely that the cardiac output is decreased. And so what we see with acyanotic heart defects is the patient tends to go into heart failure from a backup of blood since the forward effect is reduced. Now, acyanotic defects can be either shunts or obstructions. You can have either. With a shunt, we know that the direction or flow of the blood is not correct. But because it's acyanotic, we know the O2 saturation is good. So an acyanotic shunt is a left to right shunt. The blood has gone to the lungs, it has become oxygenated, but it's going back through the right side of the heart again from the left side to the right and getting oxygenated again. So it's actually going backwards through the heart. We see this oxygenated blood getting recirculated through the lungs more than once. So it's almost like doubly oxygenated. The problem is the right side of the heart has more work because it's got to pump twice the amount of blood. And that's going to be a problem. So in this particular case, we start to see issues with heart failure. Now, common acyanotic shunts include an atrial septal defect, a ventricular septal defect, or a patent ductus arteriosus. So down here on our picture, you can see right here is a ASD, or an atrial septal defect. There's a hole between. So the blood, the deoxygenated blood is going through, it's going to the lungs, it's getting oxygenated, but the problem is when it comes back from the lungs into the left atrium, it's going to move back over and go through this right side again. So the right side actually has to recirculate that blood twice. Now, a patent foramen ovale is sometimes very similar to an atrial septal defect because the foramen ovale is between the two atrias. So a PFO, or a patent foramen ovale, can also cause these same symptoms. Now, a VSD is a ventricular septal defect. In this particular case, there's a hole between the ventricles. These are actually a lot more problematic because the ventricles are a lot larger. So a larger amount of blood is actually moving back over and recirculating. So again, the blood is going to the lungs, it's coming back from the lungs oxygenated, going through into the left ventricle, but then instead of going out to the body, it's going to go back through and recirculate again. Now, we also have something called a patent ductus arteriosus, and that's when the PDA did not actually close. In this particular case, we can actually also see a acyanotic defect. Now let's talk about common acyanotic obstructions or decreased amount of flow. In most cases, stenotic valves cause this, meaning the valve is narrowed and blood can't get through the valve very well, whether it's a stenotic pulmonic valve, where there's decreased flow into the pulmonary artery, or maybe a stenotic tricuspid valve, where we're not getting good flow from the right atrium to the right ventricle. Or sometimes the valve can actually have an atresia, meaning that it just doesn't open and blood backs up. Those are obviously much more problematic. A more common thing is what's called a coarctation of the aorta. A coarctation of the aorta is actually a bottleneck in the aorta. And we actually will see it in this particular picture right here. What we see is that the blood is nice and oxygenated, so it's acyanotic. And as the blood comes through the left ventricle and pumps out through the aorta, there's a narrowing right here. And that narrowing is going to decrease cardiac output and flow to the body. Now let's move on to our cyanotic defects. Now remember, in cyanotic defects, the oxygen saturation is very low, and so the tissue is hypoxic and we have decreased O2 saturations or maybe cyanosis or bluing of the tissues in the body. So the patient may look, the color may not be nice and pink, they actually may look a little blue. So what's happening is deoxygenated blood is making out of the body, making its way out of the heart to the body tissues. And it's actually skipping, going to the lungs for oxygenation. In these particular cases, the shunt direction is a right to left shunt, meaning that it is skipping, going to the lungs, and it's going from the right side of the body all the way to the left side and then out to the body without going through the lungs first. Common cyanotic defects include tetralogy of Fallot, also known as TET, transposition of the great vessels or the great arteries, or something called truncus arteriosus. These are much more complicated disorders. With tetralogy of Fallot, this is a good picture of that right here. Tetralogy of Fallot is 4 problems. With tetralogy of Fallot, we have a ventricular septal defect or a hole between the ventricles. We have an overriding aorta where the aorta is actually picking up blood from both sides, both oxygenated and deoxygenated blood. We have a tight pulmonary valve, which now I've covered that up. Let's see if we can fix that here so that you can see that. We have a very tight pulmonary valve, so we're not getting much blood to the lungs. And the last thing is this right ventricle has gotten really thick, and so it decreases the amount of blood that's in it. So this is 4 defects in tetralogy of Fallot, and all of these defects lead to decreased oxygen saturation going out to the body. Now, transposition of the great vessels is just that. It's where the vessels have been switched. So what's happening is the right atrium is actually connected to the aorta and pumping out deoxygenated blood to the body. And in this particular case, the left ventricle is pumping to the lungs. And so in these cases, the vessels are switched. Now, truncus is where the pulmonary artery and the aorta did not divide, and they actually remained as one. So you can see here's the pulmonary artery and here's the aorta, and they actually are together here. So what's pumping out to the body is this mixture of deoxygenated blood and oxygenated blood. So we have in all 3 cases decreased O2 saturations. Hopefully that's helped you a little bit go through cyanotic and acyanotic defects. Remember, you have shunts and you have obstructions. Shunts are an abnormal flow of blood through the heart. They can be acyanotic, meaning they're moving from the left side to the right side and reoxygenating, or they're cyanotic, moving from the right side to the left side and skipping oxygenation in the lungs. Or you can have obstructions, which is narrowed flow, decreased cardiac output, and a backup of blood.